Usually when we talk about a medical diagnosis, there's this kind of underlying expectation of pure mechanical precision.
Right, yeah.
Like you break your arm, you go get an x-ray, and the image shows that jagged white line on the bone, and the doctor just points at it and says, there it is. That's the problem. Here's the screw we use to fix it.
It's it's entirely binary. Like, it's either broken or it's not broken. You have a very clear blueprint for the repair.
Yeah, exactly. And I mean, that is deeply comforting to us as patients. We like things to be visible and, easily categorized. But when you step into the world of plastic and reconstructive surgery, suddenly that neat binary x-ray machine feels completely inadequate.
Oh, completely.
You are looking at a diagnostic and surgical landscape that is just incredibly murky. Surgeons are forced to rebuild form and function from biological materials that, well, they don't always behave the way you want them to.
No, they don't. It really forces the surgeon to operate in like the absolute definition of diagnostic muddy waters. And to navigate that, you can't just memorize textbook facts. You have to fundamentally change how you think. And that is really our mission for this deep dive today.
Right.
We are stepping into the shoes of a medical student or, a surgical resident who is preparing for their final specialty exams. And to do that, we are pulling our insights from a massive medical gauntlet.
Yeah, it's a very specific source today.
It is. We're looking at a comprehensive textbook called Multiple Choice Questions in Plastic Surgery. It's by Kavan Chakrolahi, Ian S. Whitaker, and Hamish Ling. And it's designed specifically to test plastic surgeons on everything.
And the reason we are looking at multiple choice questions, or MCQs, isn't just to drill trivia at you. The foreword to this collection actually makes a brilliant point about this.
Yeah, the foreword by Robert M. Goldwyn.
Exactly. It argues that a well-designed MCQ forces you to look at a chaotic clinical problem from multiple angles, which is an approach deeply rooted in the Socratic method. You are basically evaluating competing truths to find the most optimal path forward. So whether you are a medical student, a young professional entering the field, or just someone who is insanely curious about how the human body can be re-engineered, we are going to synthesize the crucial anatomical rules, the historical milestones, and really the life-saving interventions of this whole specialty.
Yeah, and we have to start with the fundamental rules of biological survival.
Yeah.
I mean, before any modern surgeon can reconstruct a complex facial defect or, say, salvage a crushed limb, they have to understand how to move living tissue from one part of the body to another without that tissue dying in the process.
Which is easier said than done.
Way easier said than done. Plastic surgery is built on centuries of trial and error in this exact pursuit. If you look back to India, like between 800 and 600 BC, there was a physician named Sushruta who was performing nasal reconstructions using flaps of skin from the cheek.
Wow. That early.
Yeah. And he figured out early on that you couldn't just slice a piece of skin completely off and stick it on the nose.
Because it would just, die?
It would just rot. Exactly. You had to leave a bridge of tissue connected to the cheek, which is called a pedicle, to act as a lifeline for blood flow.
Right. I remember reading about Gaspar Tagliacozzi doing something similar in Italy in 1597. He was attaching a patient's arm to their nose for weeks to let the blood supply grow across.
Yeah, the Italian method.
Yeah. But the leap that really caught my attention was Sir Harold Gillies during World War I, because he was treating soldiers with these horrific, unprecedented facial injuries from trench warfare. And he pioneered something called the tube pedicle. But why tube it? Why not just leave it flat like Sushruta did?
Well, think about the environment of a World War I hospital. Infection was rampant. If you lift a flat flap of skin from the chest and attach the other end to the jaw, the underside of that flap is just raw, exposed flesh. It is a magnet for bacteria. So Gillies realized that if he rolled that flap of skin into a closed tube and stitched the edges together, the raw surface was hidden inside.
That's so smart.
Right. Only intact, healthy skin was exposed to the outside world. This drastically cut down on infection. But mathematically, it also forced the blood vessels inside the tube to align linearly, which maximized the arterial flow from the chest up into the face.
That is just brilliant spatial reasoning. We also see Peter Medawar mentioned in the historical sources sharing the 1960 Nobel Prize. But his work wasn't even about moving tissue, was it? It was about the immune system.
Exactly. He mapped out why the body rejects skin grafts from other people, and that obviously laid the bedrock for all modern organ transplantation.
Okay, so the underlying theme of all these pioneers is blood supply and tissue viability. Which brings us to the modern era. where surgeons need a highly precise map of how blood travels through muscle. You can't perform reconstructive surgery without knowing the Matthews and the high classification?
You really can't. It's foundational. They categorized every muscle in the body based solely on its vascular anatomy.
Meaning how many arteries feed it and where they enter.
Yeah.
So it's basically a manual of advanced biological plumbing. If you are going to rip out the pipes and move the sink across the room, you need to know which pipe is the main water line.
That analogy holds up perfectly. Take the gracilis muscle, which sits on the inner thigh. Mathis and Nahai classify this as a type 2 flap.
Okay.
That means it has one massive dominant artery feeding it, along with a few minor secondary vessels. If a surgeon carefully isolates that one dominant artery and the accompanying vein, they can detach the entire muscle, move it to the face to restore a patient's smile, and plug those vessels into the facial arteries under a microscope.
And it just lives.
The muscle survives entirely on that single dominant pipe.
Wow. But not all muscles are built like that. The source is contrasted with the sartorius muscle, the long one running down the front of the thigh.
Right, the sartorius is a type 4 flap, so instead of one main pipe, it survives on multiple small segmental vessels entering all along its length, like little sprinkler heads.
So there's no main artery at all.
Exactly. There is no dominant artery. If a surgeon tries to lift the entire sartorius muscle using just one of those tiny vessels, the tissue at the far ends will simply starve of oxygen and die. So this classification system tells the surgeon the absolute biological limits of what they can and cannot manipulate.
And zooming in even further from the plumbing of the muscles, the text spends a lot of time testing the microscopic building blocks of the tissue itself, specifically collagen.
Yeah, collagen provides the structural scaffolding for everything we're talking about. So type I collagen is the heavy-duty structural cable. It's what makes up your skin, tendons, and mature bone.
Right.
In fact, the genetic disorder osteogenesis imperfecta, which causes extremely brittle bones, is fundamentally a failure in the body's ability to manufacture normal type I collagen.
But the rules of collagen completely flip when you look at fetal wound healing. The sources point out that fetuses can undergo surgery in the womb and heal without a single scar. That sounds like science fiction.
It really is the holy grail of regenerative medicine. See, when an adult gets a cut, the body rushes to patch the hole quickly, laying down dense, disorganized type I collagen, which we see as a scar.
Yeah.
But a fetus operates in an amniotic fluid environment that's really rich in hyaluronic acid, and it relies heavily on type 3 collagen. This combination allows the tissue to actually regenerate its original organized structure rather than just throwing a fibrotic patch over the damage.
That microscopic elegance is amazing. But then the source material throws us a curveball and tests the reader on something decidedly less elegant.
Oh, I know where you're going with this.
Medicinal leeches. Hirudo medicinalis.
I have to admit, I thought this was a medieval practice we left behind with, like, bloodletting.
It does sound archaic, yeah. But the medicinal leech is actually a highly specialized microsurgical tool used to solve a very specific mechanical problem, which is venous congestion.
Okay, unpack that for me. Let's say you just reattached a patient's severed finger. You've sewn the tiny arteries together, so high pressure, oxygenated blood is pumping into the finger beautifully, but the veins, the low pressure outflow pipes, are too damaged to repair.
So the blood gets in, but it can't get out.
Exactly. The finger quickly turns purple, swells up like a balloon, and the pressure eventually stops the fresh arterial blood from entering. The tissue suffocates in its own stagnant blood.
Yikes.
This is where the leech comes in. You place it on the congested tissue, and it acts as an artificial vein.
Wait, really?
Yeah. The leech's saliva contains hirudin, which is a potent anticoagulant. It numbs the area, drinks the stagnant blood, and even after it falls off, that bite wound will continue to slowly ooze and relieve the pressure for hours. That gives the body time to grow new microscopic veins.
Okay, I see the mechanical logic.
Ah.
But the sources also highlight a major pharmacological catch here. You can't just, slap a leech on a wound and walk away.
No, absolutely not. You are introducing a wild organism into a sterile surgical site. To digest all that blood, the leech relies on a symbiotic bacteria living in its gut called Aeromonas hydrophila.
That doesn't sound good.
It's not. When the leech bites, it can transmit that bacteria directly into the patient's compromised tissue. An Aeromonas infection can aggressively destroy a reattached finger or a tissue flap in a matter of hours.
Wow.
Therefore, the absolute standard of care dictates that any time you use a leech, you must administer prophylactic antibiotics, typically a drug like Augmentin, specifically to hunt down that gut bacteria.
So we are basically balancing the salvation of the tissue with the introduction of a new pathogen. That idea of managing competing threats leads perfectly into how surgeons handle chaotic trauma. Because, it's one thing to move a healthy muscle in a sterile operating room, but it's entirely different when a patient arrives with severe burns.
Right, you're dealing with tissue that has just been catastrophically destroyed.
Ex-
Burn surgery really forces the plastic surgeon to act as a critical care intensivist. Historically, the management of deep burns was incredibly passive. Doctors would wait weeks for the dead, burn tissue, the Escher-2 naturally separate from the healthy tissue underneath.
That sounds like a recipe for infection.
It was a massive breeding ground for fatal infections. But the paradigm shifted in 1970 when a surgeon named Zora Janzakovich introduced tangential excision.
I was trying to visualize this from the reading. It's not just cutting off a chunk of skin, right?
No, imagine using a highly specialized guarded blade, somewhat like a precision cheese slicer. The surgeon actively shaves away the charred, dead tissue layer by microscopic layer. You keep shaving until you suddenly see healthy, pinpoint bleeding.
Because bleeding means life.
Exactly. That bleeding tells you that you have reached viable tissue. You stop immediately and cover that raw surface with a skin graft. It is an aggressive, bloody procedure, but by excising the dead tissue early, Janzakovich dramatically lowered infection rates and completely transformed burn survival statistics.
But the textbook makes it very clear that burn trauma goes way beyond the skin. There's a whole section testing the reader on recognizing and treating cyanide poisoning.
Honestly, when I first read that, I was confused. Why is a surgeon worrying about cyanide? That sounds like a spy novel, not a burn unit.
Well, consider the environment of a modern house fire. Decades ago, homes were full of wood, cotton, and natural fibers. Today, your couch, your carpet, and your electronics are packed with synthetic polyurethanes and plastics.
Right.
When those materials combust, they don't just produce carbon monoxide, they off-gas hydrogen cyanide. A patient pulled from a burning building hasn't just burned their skin, they have inhaled a lethal chemical weapon.
And cyanide acts as a cellular assassin, basically.
It does. It specifically targets the electron transport chain inside your mitochondria, which are the power plants of your cells. It jams the machinery that processes oxygen.
Oh, wow.
So the patient can be breathing 100% oxygen, their blood can be saturated with it, but the cells simply cannot use it. They suffocate on a microscopic level while literally bathed in oxygen. So a surgeon managing a burn resuscitation has to recognize that inevitable metabolic crash immediately.
Yes. And the chemical antidote is hydroxycobalamin, which grabs the cyanide molecule and turns it into harmless vitamin B12, which the patient just pees out.
That's wild.
Or, alternatively, they use a chemical kit containing amyl nitrate, sodium nitrate, and sodium thiosulfate to achieve a similar detoxification.
The breadth of knowledge is staggering. I mean, we go from chemical asphyxiation back to pure mechanical pressure with something called compartment syndrome.
Yeah, so our muscles, particularly in our arms and legs, are bundled together inside envelopes of fascia. Fascia is a tough, fibrous, connective tissue, and it does not stretch.
At all.
Not at all. If a limb is crushed in a car accident or suffers a deep electrical burn, the injured muscle tissue begins to swell dramatically. Because that fascial envelope won't yield, the pressure inside the compartment skyrockets.
It's like inflating a balloon inside a steel pipe.
Eventually, the pressure pushing out becomes greater than the blood pressure trying to push in. Exactly. The moment the internal pressure exceeds capillary blood pressure, the blood supply to the muscle is choked off. The muscle begins to die, the nerves begin to die, and the patient is at severe risk of losing the limb.
So what do you do?
The only solution is a fasciotomy. The surgeon must take a scalpel and slice open the entire length of the fascia to let the swelling muscle bulge out and decompress.
But you can't just cut anywhere. The sources are very specific about the surgical geography.
You have to unlock every single compartment. In the forearm, a single strategically placed volar incision, meaning down the palm side of the arm, can usually provide access to release all the necessary muscle compartments.
Okay, that seems straightforward.
But the foot, however, is an incredibly dense 3D anatomical puzzle. A single cut will not save a foot. You have to make a medial approach, an incision along the plantar border, which is the bottom inside edge of your foot right behind the big toe.
Right.
And you combine that with separate dorsal incisions on the top of the foot between the toes. Only by attacking it from multiple specific angles can you decompress the entire structure.
That mechanical mindset, understanding the tension, the leverage, and the spatial relationships is fascinating. And it applies to more than just trauma. It brings us to what might be the most complex engineering challenge in the specialty, which is congenital anomalies of the hand.
Reconstructing a hand that never developed properly requires an incredible blend of structural engineering and biology. One of the most tested conditions is thumb hypoplasia, where a child is born with an underdeveloped or entirely missing thumb.
And the surgical roadmap for this is dictated by the Blouth classification.
Right.
The textbook uses some pretty dense clinical language here. Let's try to visualize it like construction equipment. If a functioning thumb is basically a heavy-duty crane, if Blouth type 1 means the crane's cables are just a little loose and need tightening, Blouth type 3 means the entire concrete base of the crane is missing.
That captures the structural dilemma perfectly. In the milder Blouth types, the foundational bones and the carpometacarpal joint at the base of the thumb are intact. So the surgeon can just reroute some tendons, tighten the cables, like you said, to make it functional. Okay.
But in Blouth type 3, specifically 3B, that basal joint never formed. You don't have the concrete base. No matter how much you operate on the thumb itself, it will never have the stability to pinch or grasp. The hypoplastic thumb is essentially useless and has to be removed.
So you remove it, but you still need a thumb. You can't just graft a piece of bone from the hip and expect it to bend.
No. And this is where we encounter one of the most elegant, mind-bending procedures in all of surgery. It's called pellicization. The surgeon literally relocates the patient's index finger to the thumb position.
Wait, I'm struggling to picture this. You move the whole finger. What happens to the joints? Because an index finger bends forward, but a thumb has to swivel and oppose the other fingers. How does an index finger do that?
It's amazing. The surgeon carefully dissects the index finger down to its base, preserving the microscopic nerves and blood vessels so it stays alive. They shorten the bone to match a thumb's length. Then, they physically rotate the finger 160 degrees so the pad of the finger now faces the other digits.
But the true genius is in the joint repurposing. The knuckle joint of the index finger, the metacarpal head, is repositioned to become the new foundational basal joint of the thumb. The tendons that used to straighten the index finger are painstakingly re-anchored to become the muscles that pull the new thumb away from the hand. You are turning a hinged joint into a swivel joint.
That is architectural genius. But what about the brain? If I try to move my new thumb, isn't my brain sending the signal to bend index finger?
This is where surgical engineering meets neuroplasticity. The brain's motor cortex has a map of the body, called the homunculus. Initially, yes, the child fires the index finger pathway to move the thumb.
Right.
But because pellicization is typically done in very young children, their brains are incredibly plastic. Through intense physical therapy, the brain literally rewires its map. It learns that those nerve signals now control a thumb.
The body's ability to adapt is staggering. But sometimes the neurological pathways themselves are the source of the trauma. The sources highlight OBP, obstetrical brachial plexus paralysis.
Yeah, this occurs during a traumatic birth, such as shoulder dystocia, where the baby's shoulder is lodged behind the mother's pelvic bone. As the baby is delivered, the head and neck are stretched violently away from the shoulder. This tears the brachial plexus, which is the intricate network of nerves running from the spinal cord down into the arm.
And the test questions focus on a very specific clinical sign. The doctor isn't just looking at the paralyzed arm. They are looking at the baby's eye for Horner syndrome. They are checking for apoptosis, a drooping eyelid, and meiosis, a constricted pinpoint pupil. Why would tearing a nerve in the shoulder affect the eye?
It comes down to anatomical real estate. The sympathetic nerve chain, which controls that specific eyelid muscle and the dilation of the pupil, runs right alongside the lowest nerve roots of the brachial plexus in the lower neck.
Ah, I see.
So if a baby with a paralyzed arm also has a drooping eyelid and a constricted pupil, it tells the surgeon that the trauma was so violent, it didn't just stretch the nerves in the shoulder, it avulsed them. It ripped the nerve roots entirely out of the spinal cord, damaging the sympathetic chain on the way out.
And you can't just plug a nerve back into the spinal cord.
You cannot. An avulsion is permanent. To restore any function to that baby's arm, the surgeon has to perform nerve transfers. They hunt for a healthy, intact nerve nearby, perhaps an intercostal nerve from between the ribs or the spinal accessory nerve, and splice it into the dead nerves of the arm.
Wow.
They are literally rewiring the electrical circuit board, hoping the brain can learn to use a rib nerve to flex a bicep.
Unbelievable. Now, while we're looking at congenital and pediatric challenges, we should briefly mention craniofacial anomalies, the palate and the face.
The structural repairs, like cleft lips, are guided by tools like the Kernahan classification, which maps the anatomical defect on a Y-shaped diagram. But the textbook emphasizes that a plastic surgeon must always look beyond the local anatomy to the systemic genetics. A prime example is velocardiofacial syndrome or DeGeorge syndrome.
Right, the sources fly a specific genetic marker for this. It's a microdeletion on chromosome 22q11.2.
Exactly. That tiny genetic deletion disrupts the migration of neural crest cells during embryonic development. And these cells are crucial. They travel down to help form the palate and the mouth, but they also travel into the chest to help form the heart and the thymus gland.
So they're multi-purpose.
Very much so. So a child presenting with a cleft palate due to this syndrome will almost certainly have severe hidden cardiac defects and a compromised immune system. The surgeon operating on the roof of the mouth must be hyper-aware that the child's heart could fail under anesthesia.
It's all connected. Every structural issue has a deeper systemic consequence. And that actually brings us perfectly to our final segment, where the stakes of balancing structure and biology are at their absolute highest: aesthetic and oncological surgery. Often, a plastic surgeon must remove a deadly disease while flawlessly restoring aesthetic form, or perform an elective aesthetic procedure that carries massive hidden anatomical risks.
Those risks are terrifyingly real. Let's look at an aesthetic emergency detailed in the MCQs. A patient undergoes a routine lower eyelid surgery, a blepharoplasty, to remove some cosmetic bags. 2 hours later in recovery, they complain of a swollen, agonizingly painful eye, and they tell the nurse their vision is rapidly going dark.
The visual of that is horrifying. What is physically happening behind the eye?
The patient has developed a retrobulbar hematoma. A tiny blood vessel deep behind the eyeball has opened up and is bleeding. The anatomical problem is that the orbit, the eye socket, is a closed, rigid, bony box.
So the blood has nowhere to go.
Right. As blood pools and expands inside that box, the pressure skyrockets. It violently pushes the eyeball forward, a condition called proptosis. Worse, that pressure crushes the optic nerve and collapses the retinal artery, basically starving the eye of oxygen.
The textbook is incredibly strict about the clinical action here. It says you absolutely do not wait for an ophthalmologist to arrive.
In ophthalmology, they say time is retina. If you wait for a consult, the optic nerve will die and the patient will be permanently blind. It is a drop-everything emergency.
So what's the immediate fix?
The surgeon must immediately perform a lateral canthotomy at the bedside. You inject a little local anesthetic, take scissors, and physically snip the lateral canthal tendon at the outer corner of the eye.
Oh.
By cutting that tight ligament, you allow the entire eyelid to swing forward like a gate opening. It instantly releases the pressure inside the bony box, restoring blood flow to the optic nerve.
And the mechanical release is backed up by chemical interventions, right?
Yes. Simultaneously, you administer intravenous mannitol. Mannitol is an osmotic diuretic. It literally pulls fluid out of the swollen eye tissues and into the bloodstream. You also push acetazolamide, which is a drug that halts the eye's internal production of aqueous humor fluid. It is a highly choreographed, high-stakes medical and surgical intervention.
And that high-stakes oncological reality is an enormous part of the daily caseload, too. Cutaneous malignancies, skin cancers.
Oh, the volume of basal cell carcinomas, or BCCs, that a plastic surgeon excises is staggering. The questions often focus on recognizing when a simple skin cancer is a clue to a systemic syndromic presentation.
Like what?
Well, for instance, if a teenager develops multiple BCCs, they likely have Gorlin syndrome, which is a rare genetic disorder. Or the surgeon needs to know that a BCC can aggressively arise from a pre-existing, harmless-looking birthmark on the scalp called a sebaceous nevus of Jadison.
But the textbook reserves its most rigorous staging questions for melanoma, because how you stage it dictates the entire surgical battle plan.
Exactly. The American Joint Committee on Cancer, the AJCC, provides the staging criteria. The test forces you to understand the specific prognostic factors. It isn't just about how wide the tumor is.
Right.
The surgeon looks at ulceration. Is the skin over the tumor broken? They look at Clark's level, which measures exactly which microscopic layers of the skin the tumor has invaded. They draw blood to check lactate dehydrogenase, or LDH, because elevated levels suggest the tumor is already metastasizing to distant organs.
But the sources also highlight an interesting evolution in the staging criteria regarding the mitotic rate. What is that, and why did it change?
Mitotic rate is simply a measure of how fast the cancer cells are actively dividing under a microscope. Older editions of the staging manual excluded it from certain early stage criteria, but modern oncology realized that an aggressive mitotic rate is a massive independent predictor of how lethal that tumor will be.
So it changes the surgery.
Completely. If the cells are dividing furiously, the surgeon knows they must take significantly wider margins of healthy skin during the excision to ensure they capture every microscopic stray cell. It proves that as our understanding of tumor biology evolves, the surgical algorithm must adapt in real time.
And that adaptation is exactly what we've been tracking today. We have journeyed through the staggering breadth of this medical specialty. We've gone from mapping the biological plumbing of Matthees and Nahai SLAP classifications to the mind-bending neuroplasticity required when relocating an index finger during pellicization.
Yeah, we've covered a lot.
We've seen how a surgeon must instantly pivot from routine aesthetics to crisis management, snipping an eyelid tendon to save a patient from blindness.
It demands an unrelenting synthesis of structural engineering, biology, and sheer nerve. Which brings us to the review exercise we promised for our medical learners listening in.
All right, rapid-fire clinical scenario. You are the resident on call. A patient develops immediate, severe proptosis and visual loss 2 hours after a lower eyelid blepharoplasty. What is your diagnosis, and what are the 3 immediate steps you must take at the bedside before calling a specialist?
Take a second to lock in your answer. The diagnosis is a retrobulbar hematoma. The 3 immediate steps are: perform a lateral canthotomy to mechanically decompress the orbit, administer intravenous mannitol to pull fluid from the tissues, and administer intravenous acetazolamide to halt internal fluid production. If you can recall the mechanics behind that sequence, you are thinking exactly like a reconstructive surgeon.
Perfect. We want to leave you with one final provocative thought. We started this deep dive talking about Sushruta moving a flap of skin from a cheek to a nose in 800 BC. But today, the frontier of the specialty is composite tissue allotransplantation.
We are talking about transplanting entire human faces from a donor to a patient. The pure anatomical hurdles, the plumbing of the Mathas and Nahai vessels, the microscopic nerve splices, have largely been conquered.
Which is incredible on its own.
It is. But here is the profound challenge. The acute rejection rates for facial transplants are estimated to be anywhere between 10% and 70%. The future of plastic surgery is no longer just about mastering the scalpel or the suture. It is about mastering the immune system itself.
Wow.
How will the reconstructive surgeon of tomorrow balance the flawless recreation of human form with the dangerous, complex biochemistry of lifelong immunosuppression? It is a question that forces the entire field to look at the human body from an entirely new angle, something to think about as you continue your own clinical training.